you do that is you incite a revolution, a cellular revolution in the wound bed. Wow, that's pretty radical. We're going to cause a revolution. That's true. We're going to tell cells very effectively to come together to form this beautiful basis for granulation tissue so that we can start to heal. Doesn't matter what the etiology is. It could be vascular, it could be pressure, it could be surgical, it could be skin tears, it could be diabetic, neuropathic, it doesn't matter. And I'm going to show you how that's going to be accomplished. So there's a lot of information here. We see growth factor liberation. All right, look, angiogenesis. Angiogenesis from the Greek means new blood vessel. Genesis, the beginning of angio, blood vessel. So we're going to incite new blood vessels to come to that tissue because look at it in this fashion. If you have a plant, you don't water the plant will die. Same concept. Same concept. So we have angiogenesis. And then we have protease releases because this is our modulating protein, modulating enzyme. We don't want to have an over-liberation of collagen because if you do, you have a fibrinous product. We don't want fibrin. We want to have a wonderful balance. We want to heal the wound without having a scar. And we will achieve that with these products as I will demonstrate. So we see fibroblasts. So the key is the fibroblast has influence on many cellular mechanisms to be able to get that wound to a point of resolution. That's the key. Okay, so we see here, this is basically a summary of the previous slide. We know that the collagen and the fragments are chemoattractants for fibroblastic migration. Point A to point B. When we get to point B, we'll be able to heal that wound. All right, so that's a very important take-home. Now, what about macrophages? Okay, I want to mention macrophages as being part of the important process of wound healing because macrophages are also called the garbage truck cells. They go around the wound and they will attract and engulf cellular debris and slough and devitalized tissue. Because when we heal a wound through the development of granulation tissue, we don't want any devitalized tissue in there. So the macrophages are very integral to wound healing. Also know that they have other subcellular influences similar to fibroblasts. So you have the fibroblast as the main cell, and then you have the macrophages hanging out here. They're working together in some sort of synchronous relationship to get to the end result, and the end result is wound healing. So there's a lot of things going on. And I come back to the old statement I just made before. We're causing a cellular revolution in the wound bed. That's exactly what we're doing. We're using collagen as the initiator molecule to get all of these processes underway. Very important. Okay. What's the difference between an acute and chronic wound? A lot. But by definition, if an acute wound is not resolved in about 6 weeks, correct? We call it chronic wound. And there's a lot of things that go on in a chronic wound. So the number is about 6 weeks. So look what happens in a chronic wound. We have bioburden increasing. We have exudation increasing. We have a lot of bad cells increasing. But look at it this way. I try to bring all of these technical things to a very common understanding. And here's what I want to tell you. Think of this as a swimming pool. If you don't put chlorine in the swimming pool, you're going to grow algae. Who wants to swim in a swimming pool with a lot of algae? It's not right. So what you have to do is you have to modulate the chemistry of the wound. Modulate the chemistry of the wound. Bring it back into balance. Because if you bring it back into balance, you'll heal. You'll heal the wound. Because if you bring it into balance, you're reducing the bacterial bioburden. and you're allowing the fibroblasts to come in, and you're allowing the macrophages to respond very efficiently. Here's what I'm going to do. Let us assume that this is a chronic wound. And if you see that there, chronic wounds, we have a lot of exudation, and we'll also have a terrible enzyme called the matrix metalloproteinase and MMP. So here's what I'm going to do. I'm going to demonstrate that this right here is going to be a chronic wound full of exudation. Full of exudation. As I said before, in order for that to heal, we need to control the exudation. I'm going to show you the best product in the world for managing highly exudative wounds. It's called gold dust. It is a hydrophilic polymer composed of unique properties that absorbs 100 times its weight of exudation. So I'm going to take this and pour this in here. And we're going to see how much this product is going to absorb. I've put 3 grams of gold dust in here. It's doing its job. Okay? It forms a hydrogel. It forms a hydrogel because here's why. We want to maintain a moist wound environment to induce optimal wound healing. So let's leave this here for about a couple of minutes. You see? I'm a physician, not a magician. But you're going to see a good magic act, and you're going to see that this whole, look at this, how this is amazing, all right? Let's leave this here for about a minute or two, and we're going to see that regardless of what causes the exudation, you're going to control the exudation by using this product, gold dust. Why? Because if we modulate the chemistry of the wound, we'll be able to heal it efficiently. So once we use the gold dust and we've controlled the exudation, then we can put collagen into the wound bed. This is 100% type 1 collagen. It's hydrolyzed activated collagen, which means that once it goes into the wound bed, it responds immediately to the fibroblasts. There's no delay. Okay? So we have this here. So that is a very important goal that we need to achieve as clinicians. We're at the bedside, and we have a wound that is really difficult. And sometimes we know in stage 4 pressure ulcers, where we have exposed bone and tendon, let's talk about the coccygeal area where the tailbone is. Those patients are difficult to heal. Difficult to heal. But you know something? When you use the gold dust, okay, I'm going to give this to you to pass around. This is non-toxic, it's sterile, but you feel it. It's a hydrogel. Pass this around, please, so everyone can see this. Amazing stuff. Amazing. So that's one of our clinical goals, to manage that. So I wanted to emphasize the ability of what the difference is, acute, chronic, and how are we going to address this? How are we going to address this? There's your solution. Okay, wonderful solution. All right, diabetes. We see global pandemia of diabetic incidence, where the incidence, some countries, for example, Saudi Arabia, the incidence of diabetes is about 35%. In the United States, it's about 8%. Philippines is about 25%. I've traveled to the Philippines 6 times last year to lecture, and they have a very bad problem with the incidence of diabetes. The Middle East has a very high diabetic population. So what's the point? We are going to be managing patients who have diabetic wounds. And the bottom line here, the pathophysiology of these wounds, is that the body cannot produce collagen because of a metabolic deficiency. So what are we going to do? We're going to give the collagen to the patient so that they can produce granulation tissue no matter how bad or how uncontrolled their diabetes is. All right? So we see here that this is